Thank you very, very much. It's an honor to be here at your university and to see the interest in post-traumatic stress disorder. Post-traumatic stress disorder is a big topic, and I know we don't have a lot of time. If I hear your agenda, we're going to go to about 11:15, take a break, and then come back after that and finish up before noon. So there's a lot to do. If I don't cover everything, and I probably won't, I will, through Chaplain Sita, who's actually become part of our program. He's actually doing two of the groups we do up in West LABA. I'll give you my card, and I'll answer any questions later if you want, or you want to come up and see the program. I'll be happy to do that. Yeah, I'm a Vietnam veteran. I was a combat veteran in Vietnam. Spent 13 months in combat, and my road to this work has been, to me, an interesting journey because it was unplanned. But every time I speak about post-traumatic stress disorder, I think in terms of the evolution of post-traumatic stress disorder, PTSD was first recognized in 1980. So it's a relatively new disorder. It was called many, many things before. One of the first people who spoke of post-traumatic stress disorder was Abraham Lincoln. Lincoln used to visit the hospital wards, and he would see the Union troops who were badly injured, both physically and psychologically, and he termed the phrase "soldier's melancholia," kind of a sadness, and from that, they spoke in terms of the soldier's heart. In World War I, it became shell shock because they started using shells, and they thought there was kind of this inner ear disturbance that came from shells. In World War II, it was combat neurosis, combat fatigue. 1958, it became gross stress reaction. And in 1980, thanks primarily to the advocacy of the Vietnam veterans, it was recognized in the DSM. If you don't know the DSM is a manual that is used in mental health, and it's a great big book. It's a big, thick book. It's got thousands of pages in it. And in order for a diagnosis to be recognized by the mental health profession and insurance companies and hospitals and whatever, it's in that book. And it hasn't changed very much. That's about 34 years ago that it was first introduced, and they've changed it a little bit. We now have the 5th edition, so they've modified it a little bit, but it's not dramatically different. So today I thought what I would do in our brief time together is talk a little bit about the past, a little about the present, and about the future. And there's a lot of work going on with post-traumatic stress disorder, and some really exciting things as well. I always think that when you give a workshop, and I've given a lot of these, being of an Irish heritage, I like to tell stories and do narratives, but I think in terms of the evolution of PTSD in my own life and in my own experiences, I was, as you can probably tell, I have a New York accent. I'm from New York City, and born and raised there. And it was a really lovely place to grow up. It was before a lot of problems that New York had, and it was a safe and contented place. And I was in the 5th grade. I was about 10 years of age, and a little girl I knew in the grade below me in the 4th grade was murdered. She was murdered by our grocery boy. He killed her, stabbed her 38 times on a rainy Friday afternoon. It's funny I remember these things. And that was devastating. We had never known that, we had never experienced that, and all of a sudden this kid we knew, this little girl we knew, who was about 9, was murdered by this grocery boy. And the grocery boy in those days, I know things are different now, in New York, the groceries were small groceries, mom and pop, and they would deliver your food to you. And this grocery boy was in our house many, many times. And who knows what demons were going on in his brain, but ultimately he snapped and killed this girl. Well, it was devastating, to say the least, just devastating. I went to parochial school, and she was murdered on a Friday, and we went back on Monday, and nothing was said. It was like the elephant in the living room. It was a secret. Nothing was done, nothing was offered. The school did not want to, I mean, it wasn't their fault, but they didn't want to acknowledge this. So we didn't do anything with it. It's as though she was a nun person. She disappeared. And that lingered, because I really think, the community has to really treat PTSD, because the people that are damaged by PTSD are members of our community, and it will take an effort of the community to do something about it. But we didn't do anything about that, and the school I went to didn't do anything about it. No one wanted to talk about it. Well, years later, I was living out here and I had a young son. He was now 24, but he was a little boy, and he went to another parochial school. And a terrible thing happened. One of his classmates hung himself. It's a terrible situation. He had a fight with his mother. It was Halloween, and he wanted to go trick-or-treating or whatever it was, and she said no, and he went out there and killed himself. Devastating again. But the difference this time was that there was tremendous effort to help. I volunteered to help. There was a minister. It's a Methodist school, so it's a minister who came in and helped. The family spent money on hiring people to come in. No stone was left unturned to help our kids in the school, the teachers, so on and so forth, come into it. And it was a remarkable effort. Still the pain was there, still the sense of loss, but at least people had an opportunity to talk about it and to understand it. And something you'll see a lot in PTSD is a lot of survivor guilt. It comes with the territory. And a lot of people will say that, the if question, if I would have done this, if I would have done that, whatever. It wasn't meant to be. And in talking to others and getting kind of a feedback from other people about what we're truly responsible for and what we're not responsible for, helps a great deal. So survivor guilt is an important part of this. So that really is the evolution of PTSD kind of globally. It went from kind of, at best, indifference, where no one really wanted to deal with it, or you'll get over it. I mean, that's something that in the old days we would say, you'll get over it. Well, some people do, but most people don't. And to the idea that maybe there's some really good, clean, meaningful, humanistic intervention to help those who suffer. So that's a little bit of what the evolution is now, and I think Vietnam veterans, me being one of them, have some questions sometimes about the meaning of our effort, and I think if nothing else, that the Vietnam veterans really made the world aware of post-traumatic stress disorder and introduced PTSD to the world. And as you know, the world has many suffering people, and PTSD work helps the suffering, and we thank the Vietnam veterans about that. A real quick aside, when I got back from combat, I went to the university. I had a degree in economics, and I was in business world. I was in the textile business in New York, and another Friday, actually, Fridays are bad, I think. Another Friday, the man I worked for, who was a textile billionaire, or millionaire in those days, was shot to death. He had gotten involved in organized crime, and he was desperate for money, and I didn't know it at the time, and he was shotgunned in his limousine in Park Avenue, New York City. So, I saw some signs here that maybe I got to try something different. You know, this is getting a little dangerous out here. I mean, I survived Vietnam, and I came back, and my boss gets killed, and maybe I'll do something more humanistic. Maybe there are no accidents. I had gotten a correspondence from the VA in Vista, which was the Domestic Peace Corps. I think they're still in business. And they wanted to start, they were concerned that a lot of Vietnam veterans were not coming into the VA. And that was actually true. There was a lot of things going on. The Vietnam veterans were younger, they were more poly-drugged abused. The VA was really, in many ways, a World War II command and control, top to bottom system. Many of the veterans had authority issues, and so it didn't work. So they wanted to fund a special program. There were two of them. One was in Wichita, Kansas, and one was in San Francisco, and it became the prototype of the vet centers, these community counseling centers, and I had the privilege of working in the first one. And that became my life's calling. I've been in it ever since, which is a long time ago. We deal with PTSD. PTSD is an anxiety disorder. I think last time I counted, about 16 of them. And PTSD comes from both man-made incidents and events like wars, crime, rape, incest, the shadows, and PTSD comes from natural disasters, hurricanes, whatever. We do know that in most cases, people that are involved in man-made traumas have the most difficult time. Man-made because if they're natural disasters, many people put it up to God, intervention. Things happen, you can have hurricanes and rain and floods and storms and the whole thing. But with man-made trauma, there's this element of why. Why did it happen? Why was I here? Why did this happen to me? And it's a question that I know people in chaplain service deal with. It's kind of existential despair or angst and finding meaning in trauma. And Chaplain Sita is now part of the two groups that I have going up there, and he's helped with this dimension of PTSD. So real quickly, PTSD is when someone faces a life-threatening event, and that's very, very important. It's got to be a life-threatening event. And when and I'll say he, because we work with males primarily, I don't mean to discount the females, but when this soldier deals with a life-threatening event where he feels helpless, hopeless, out of control, and feels annihilation or death, when he deals with that, it changes in himself, inside, it changes the way he looks at the world. In most cases, he does not deal with it. He may be in operations, he may feel less than a man talking about it. We had this discussion Thursday night where the guys were saying that they feel less than manly in talking about these things. And of course, we try to persuade them that real men man up and talk about these things that bother them because they become better men that way. But that's something we have to deal with in dealing with kind of a macho kind of culture in many ways. So you have this collision with this life-threatening event. It alters the way you change about yourself and the world. And part of you, part of this soldier wants to deal with that event. It becomes frozen. And I realize that with combat soldiers, we're talking about events. You'll have numerous life-threatening events. But what you do is you freeze the event to keep it out of mind's way because it hurts so much. And then there's this battle that goes on. We call it push-pull. Part of the person wants to deal with that event, and part of them does not. And that's where the symptoms form, and I'll mention those as well. Probably the thing that, even with mental health clinicians who deal with this all the time, one of the big differences of trauma and what we call adult adjustment disorder is that if you live long enough, and I'll be 67 in November, so I'm even older than you are. I'm an old guy now. If you live long enough, you're gonna deal with a lot of things. And I don't know how many boxing fans we have, but I use a metaphor of boxing. Life does things like, there's divorce, there's bankruptcy, there's losing your job, there's foreclosure, there's terrible things that happen to people. And I call those life slaps. Trauma is like going in the ring with Mike Tyson when he was in his prime and taking a punch from him. It's quantitative and qualitatively different. The idea is that most people, thank God, will not suffer trauma. They will go through normal life situations, including loss. It's part of the way it is. And we get a lot of confusion sometimes about that in people who refer to us. Guys going through a bad divorce, guys this or that. Again, they're terrible things, but they don't constitute trauma. Trauma has to be a punch in the face by Mike Tyson. It's got to be qualitative. You have to be fearing for your life. It's a life-threatening situation. So, you go through this, you have this collision with this event, you freeze the event, or events, and then there's this war within we talk about. And the war within basically is 3 groups of symptoms, what we call clusters or groups of symptoms, that come from either wanting to face the event or run away from the event. Remember, push, pull. One of them is intrusiveness. That's the part of the veteran who he's trying to deal with that event, and his subconscious and preconscious is trying to deal with it. And he's going to have things like dreams, nightmares, flashbacks, which we used to call dissociation, where people go back to Vietnam or go back to Kuwait or for a brief time. And what we talk about, rumination of ideas, thinking about it all the time when they don't want to, whereas it's always kind of there and they can't quite get it out of their system. So you've got all these kind of intrusive symptoms trying to help this guy deal with that event. It's very uncomfortable, and most people don't like that. I don't blame them. And what they do is they then reverse, and they change gears, and they go to denial. They go into isolation, withdrawal. Often substance abuse is part of this. At least in the VA system, probably, this is nationally. Well, we have 2,000 veterans in our program, and 80% of them have substance abuse issues. Now, would they have been substance abusers anyway? I don't know. But certainly, in a combat situation, didn't help matters. So they had a large incidence of substance abuse. So another thing is that with PTSD, this withdrawal, we have the intrusiveness I mentioned, I've got the denial, and the withdrawal part of it is going to be when they really start fearing anything that is similar or analogous to the trauma. So in Vietnam, we had a lot of rain, monsoons. And so a lot of times with these veterans, because we don't have it out here lately, but when it rains out here, if you can remember that, when it rains out here, it often triggers some things that happen over there. We call those emotional trauma triggers. And so what happens is this person becomes very, very socially phobic in many ways. I mean, if you deal with a lot of these veterans, it's going to be challenging for them to come back to the university and sit with other people and be with other people. I know they're struggling to do it, but it is a struggle. This is part of this kind of social phobia they go through. So that's the withdrawal part. Another part of it, and a part we see a lot of, is hyper-alertness or vigilance. Now, when I was in combat, when I went through my training, we were trained to be hyper-alert, hyper-conditioned, because that bush moving over there maybe wasn't a lizard, maybe it was an enemy soldier. So you had this hyper-conditioning, hyper-alertness that in most cases really helps in combat. It helps keep you alive. But when you come back to the States and become a civilian, it adds to problems. And that's the stereotype of the guy who, the car backfires and he hits the deck, or things that are not the trauma are analogous to the trauma. They're similar to the trauma, and his brain doesn't know the difference between that. So hyper-alertness is very, very important part of it, and that symptom cluster often brings people into treatment. So that's what you have in post-traumatic stress disorder. You have the person facing a life-threatening event, helpless, hopeless, out of control, fears death, doesn't deal with it, it stays there, it's frozen, and then he has these three groups of symptoms: intrusiveness, I mentioned earlier, the dreams, the nightmares, denial, isolation, substance abuse, hyper-alertness, kind of uncomfortable in his own skin. Now, PTSD goes from relatively mild. Now, if you suffer from it, you suffer from it. I never, when someone comes before me, they're the most important focus, and their issues may be relatively less severe than others, but PTSD does run from what we call subthreshold to what we call profound or complex PTSD. And one way to look at that is that in the DSM, if there are, it's like a cookbook, if there are 10 things you need for the diagnosis, and maybe you got 2 of those, maybe that's subthreshold or PTSD light. If you got 7 of them, it's more profound, it's more complex. Now, we know now, because there's been a lot of research on PTSD, that there are variables that make the PTSD worse. And one is age. The younger the person is when they're traumatized, the more damage there is. Basically because of brain development, the brain is developing, and also social learning. Some youngster is learning how to deal with himself in the world, and his trust gets violated, he gets traumatized when he's not quite ready to, he gets a distorted view of the world. So age is very, very important. The biggest predictor, though, of the severity of PTSD is the number of events you go through. So you go through 1, bad. You go through 15, it's worse. The other is homecoming. The third one is a factor, how these veterans are treated when they come back. Are they invited back into the community? Are they invited back to the circle? Are they honored? We have to separate war from warrior. Oftentimes we may have negative feelings about a particular war, but these men and women serve us, and they're to be honored and respected and helped. In the war they may be involved with may be illegal and the whole bit, but we try and separate that. So treating the veteran that comes back is very, very, very important, and it does kind of take a community. So and the fourth part of this is, I mentioned homecoming. That's the third part, which is we often call the second wound, because you get someone and they risk their lives and they're traumatized, and they come back and they're traumatized. That leads to the second wound. The fourth is coping skills. There's some people that are naturally blessed with being very stress hardy. And there's a lot of theories about this. One theory is amino acids seem to help us with stress. I know when the Army now is recruiting people for special forces, they often test their amino acids because they think physiologically there may be something going on there. But there are people that are able to withstand tremendous stress and somehow be okay with it. Now, they may be in denial, or they may be able to kind of just deal with it, integrate it into who they are. We do know that numbers-wise, and this is both for military and civilian trauma, that 25% of survivors who go through a traumatic episode will have long-term trauma effects. So you get 4 people in a room, they're all going to be affected by it. They're all going to probably need help with it, but 1 out of that 4 is going to have some real problems. And it may be related again to the age and whatever. And I'll do a really quick story. When my son was young, I used to volunteer in my program, and one day, Dad, what's the worst case you ever worked with? And I said, well, we're trained in mental health, and whoever's in front of you's got the worst case. But I thought about it, and a guy who really fit the pattern of this, his name was Tony, and he's a Korean War veteran. So it's a long time ago. He came into us relatively late in his life. He's still alive, thank God, and doing well. But he was an interesting guy. He was born in San Francisco, and his mother was a prostitute, and his father was an alcoholic. And they just kind of left him, like, see you later, the your thing. So he was left to kind of comb the streets of San Francisco and survive, and very, very badly traumatized. He goes in, goes to foster care and this and keeps on escaping and coming back. And so he has a very, very disturbed childhood, to say the least. Goes into the Army for a better life, goes in the infantry, goes to Korea. If you know anything about the Korean War, brutal war, tough war, they're all tough. But that had also the elements in it, extreme cold, extreme heat, and he gets captured. There's 18 months in solitary confinement in a North Korean camp, and they just brutalized him totally. Somehow gets liberated, gets saved, comes back to San Francisco, no homecoming, no wife, no family. He was a kind of a big, tough guy. I don't know if you remember Telly Savalas. He looked like Telly Savalas. I'm showing my age here. Big, strong guy. And he goes to work for the mafia, and he starts collecting bad debts from people. So what he does is he comes back to civilian life and replicates the trauma. So this is a guy that has trauma everywhere. He's he's had trauma when he's been a very young child. He's been 9 years of age. It gets worse. Combat, POW, streets of San Francisco, hundreds and hundreds of events, whatever. The nice thing about it is that the postscript on this is that although we couldn't do groups, because the North Koreans had used group therapy to kind of torture, basically, and so he couldn't do groups. He was I didn't know that at the time, and he was terrible in group, and so he took me out of groups. He did some individual work, and he also we have a garden program, and he learned to grow things. He went from this life of destruction, of victimhood, of tragedy, to this growing life, and it was nice. He met a very nice young lady. She was younger. She gave him some children, and they moved up to Washington State. And a year from every Christmas, he's done very, very well. So it can happen. So those are the factors to look for. Most of the serious trauma of our veterans is going to happen between 18 and 25, 18 years of age to 25 years of age. Very, very critical time in brain development, and probably some of the people you work with will be young men and women, although you may get some of the older people as well. But most of the ones that are dealing with the recent, more acute PTSD, are coming from our current wars. Where does this all fit in mental health? Well, mental health is also on the continuum. It goes from neurosis to psychosis. Neurosis being mental health light. Everyone's a little neurotic in a way, they say. You know, maybe you gotta wear a blue shirt on Saturday, or read the paper, right to left or something. Those are no big deal. Everyone's got them. Usually they come from childhood, from coping. It's no big deal. On the other end of that is psychosis, which is a brain disease, a very serious brain disease, and they're not exactly sure why people become psychotic. There's a very strong genetic component to it. There's a social component to it. There's a substance abuse component to it. We have people that drink all their lives and use dope all their lives, and their brains become psychotic. So, there's, on the other end of the continuum, psychosis is a gross distortion. It's usually filled with seeing things that aren't there, hearing things that aren't there. You know, the CIA made me do it, or the dog made me kill my neighbor, or this one's saying this about me. It's a tragic, tragic disorder, disease. And PTSD is neither soft like neurosis or hard like psychosis. It's kind of in the middle. It's an anxiety disorder. And what I'll do, maybe I'll just say something more than that, and after the break we'll come back. But it's anxiety disorder that is related to fear, and that's the biggest difference in the other 15 anxiety disorders. This has to be the PTSD we deal with, and you'll see, and maybe friends or neighbors or family deal with, is related to an objectable feeling that these men went through. So what happens is we've got this great thing called our brain, about 3 pounds of jelly, and it's evolved. You know, our brain got larger, and you believe in God or science or both, but the brain got larger, and the brain, our ancestors, now they're saying now that everyone in this universe, you know, all 7 billion, are related to 6 original people that roamed the earth. I don't know if that's true or not, but we have more similarities than differences. Most of the differences are all superficial. So anyway, our ancestors, probably in East Africa, were living in the caves and surviving, and they had this fairly small brain. We call it the reptilian brain, the primitive brain, the reptilian brain. And we still have that. We still have that part of our brain. And it's got parts of it that really are related to stress. But what happened is we needed God, science, whatever, again, what you believe in, gave us the opportunity. We got rid of some bones and the brain grew and it needed to do more things, and now it's a complicated, beautiful part of our lives, what it can do. It's enormous things it can do. But this part of the brain, most of this part of the brain, is about being civilized, discussion, negotiation, spirituality, the things that make us truly human. This is like a firewall that protects us from this primitive brain. Now, part of that primitive brain's got a couple of things in it. It's got something called the stress response system, which is from our ancestors. That hasn't changed very much. And that gets kicked in when you are stressed, particularly when you're life-threatening stress. So, I always give this example. We're in this really nice room, and a grizzly bear comes in. There's actually been some grizzly bears lately. So I've been telling this metaphor for years, but maybe I should use this one. Well, anyway, the bear comes in the room, which is a life-threatening situation. I see that bear there, all of us. We see that bear. My brain is going to say, bear, big, ugly, mean, killer. That's going to go directly to my stress response system. It's going to bypass all this other sophisticated stuff. Why? Because this brain wants me to survive. So my stress response system is going to do three things. One is it's going to tell my body to pump more blood. It's going to instruct my body, pump more blood. Why? You think better when you have more blood in your brain. So your blood pressure is going to rise. The other thing is your temperature is going to rise. Why? Because you're gonna get out of there. You're either going to fight or flight. So you're like an athlete who needs to have the body warmed up to do your thing. Most importantly, the stress response system is going to manufacture hormones. Now, there's a bunch of them, but two of the most important ones are adrenaline, which you all know of. It gives us strength. You always read in the paper, some kid was underneath a car, and you see this poor kid in the car, and these guys lift this car. It's impossible. I mean, physics say you can't do it, but that's adrenaline. So the body's going to manufacture adrenaline. Most importantly, the body's going to manufacture cortisol. Cortisol is a hormone that's part of anger. Simply put, when people are like angry all the time, we call them angerholics. When people are angry all the time, they've got too much cortisol. Their bodies are manufacturing too much of it. So, when you see that bear, or you see the enemy soldier, your primitive brain, my primitive brain, is activated. Blood pressure, temperature, hormones. Now, that's a real objective fear. PTSD is acting as though there's a bear in the room when there's not a bear in the room. But the brain doesn't know the difference. So the guy that's been traumatized, I'm going to make this up with a bear, the guy has been traumatized by the bear, he sees bears in a lot of places. Although intellectually, he knows, well, you go to Vegas and see a bear, or the zoo, or the circus. You have to, there aren't bears running around here in most cases. I might have to change that story a little bit, because they have been coming around a little bit. I have to change that one. But You know, it's like the guy who's got the hammer, everything's a nail. His brain is getting filtered to see bears or the enemy soldiers or the rapist or the thug who mugged him. He sees that kind of everywhere. So what we do is, in a quick example, you know, the guy who's been traumatized, let's say by combat, and he goes into the VA, he has a fight with the clerk, and rather than using this part of the brain that says, yeah, I'm having a difficulty today, you know, the clerk is disrespecting me, whatever, it doesn't go to that part of the brain. It goes to the primitive part. So that clerk becomes the enemy. And that's the difference between fear and anxiety. Remember, fear is real. This stuff really happened. Anxiety is acting as though it's going to happen again. So if your brain is attuned to that, as I said earlier, you're going to see bears in a lot of different places. You're going to see enemy in a lot of different places. In most cases, that's just not realistic, and it's not an intellectual problem. These are usually very smart people we work with. It's emotional. It's an emotional thing. I mean, I'll do a real quick story, then you probably won't have your break. But I do a World War II group, interesting group, and tragically those men are all kind of dying on us. They're all very old, and I started that World War II group many, many years ago. It used to be a full house, and now I've got about 4 or 5 left. They're dying in record numbers, and they're really heroes. I mean, they're really great, great people. Well, anyway, this guy was a very bright man. He had a PhD in pharmacy, and he had been he was a sniper in the Philippines, World War II. And I do the orientation for all the new patients, and although I've cut that down, I used to do 4 sessions, now I do 2. In the old days, I used to say, well, what's your expectation? What do you want out of the program? So I would know. And he said to me, well, Jim, his name's Joe, Joe says, well, you know, what I would really like to do is, I would like to go to my house. He lived in the valley in Encino. He said, I'd like to go to my house, and I'd like to sit in an easy chair and read my newspaper with the window open. I said, sounds good to me. You know, I'm all for that. But why can't you do it? He said, well, I'm terrified of snipers. And I said, well, I mean, we have them around, and it's not impossible. And where do you live? In Encino. And I said, well, any particular type of snipers? He said, Japanese snipers. And I said, well, I don't think, intellectually anyway, there are too many Japanese snipers in Encino right now. And I wasn't funning him. I was just trying to make him see that it was kind of, kind of irrational. Well, what he had done was, he had been a sniper himself, but he lost a lot of his own men to snipers. And back in 1943, that was a real fear. When he said this, which was 2005 or something, that was an anxiety. One was based in reality, one was based on almost it's a fantasy. It's not really, but it's an emotional thing. He was so highly conditioned that you never put yourself in a vulnerable spot. You never, under any circumstances, even if it's in your house, the window open, reading the newspaper, well, because he saw, when he was in the Philippines, what happened to guys who did stuff like that. They'd be eating a meal, or they'd be reading letters, and they get killed. So that's an example. That's an example of a fear and anxiety. And that's a very, very important distinction. And in our treatment programs, we really try to point out to the men we work with, and by the way, in our particular program, we only work with men. because there are female programs, there are programs for female veterans, because we try to commingle, and it hasn't really been very successful. Many of the ladies have kind of sexual abuse issues, terrible things that happen in the military, and the last thing they want to do is go into a room full of men, and so we respect that. And the guys are annoying them a lot, and you know, asking them for dates and stalking them and all that. And so we cut that, and we said, well, we started another program for our female veterans that's staffed by all females, and it's an excellent program, Dr. Yeager, and they do much better in that particular program. So again, that's the real difference between, and that's an important, if you get any concept today, most of the people you're going to be working with are dealing with anxiety. They're not dealing with fear. Now that gets complicated, because I have guys that live in high crime areas who carry guns, and you know, the areas are unsafe and they're violent, and you know, I mean, I don't discount that, but they're not going to face a Japanese sniper in the Philippines ever again, and I can guarantee that. So that's a very, very important distinction on that, between anxiety and fear.